With this background, I'm going to ask Dr. Jasjit Suri, who's going to be speaking on AI in carotid imaging and predicting stroke in acute coronary syndromes. He's got a pioneering work and more than 100 publications on this subject in carotid imaging and intima media thickness and also plaque characterization and association with predicting cardiovascular diseases, different types of cardiovascular diseases. So over to you, Dr. Jasjit Suri.
Thank you, Professor Khanna, and good morning to everybody from San Francisco. I hope you can hear me. Let's see if I can open the slides quickly. So this is the opening slide. Just to, to give you an idea, we have been doing AI for over 15 to 20 years, but the last 7 years have been very aggressive. As you can see on the left, it shows the machine learning contributions. And on the right is deep learning, which started about 5 years ago. It's almost, we are in linear line with the contribution as well. So already Dr. Das told about the deep learning being subset of machine learning and a major subset of artificial intelligence. I say only one word in deep learning is the layers are large and the feature extraction is omitted and everything is automated. That's the one thing we have to remember. It is deep means many, many layers of neural networks, and automaticity, the removal of the feature extraction from machine learning to deep learning. So we are going to only focus on cardiovascular, really coronary artery disease, and using the surrogate biomarker that is a carotid imaging for prediction of CVDs and coronary artery disease. So again, the same concept of feature extraction comes down. We're given an image, how can we get features out of it so that we can get these features to the classification problem. So we use some kind of convolution network, as Dr. Das was saying, and do some kind of pooling operation to extract the features and keep doing that till we get the features out accurately. So here's a simple standard pipeline where you can get the wall segmentation using the deep learning and hybrid deep learning, quantify the wall, and then categorize the wall. So this is the most fundamental architecture. And if we can understand this architecture, I think we'll be in a great shape. This was done by Olaf Ronberger from Germany. And this gentleman wrote the first article on UNIT, which has got almost 40,000 citations. It's a mother of all deep learning algorithms. So what happens is you take an image, you do the convolution, the image size is given on the vertical line along. And as you go along, it becomes thicker and thicker. So what is happening is we are trying to make a teacher. And once the teacher is ready, then the teacher starts training the students. That is the most fundamental concept. So how can he become teacher? By knowing the ground truth and mimicking the ground truth. And that process is called encoding process, learning process. So he learns and extracts the feature by some convolution operation. And then he goes down and do a max pooling by getting the features out, then going again down by reducing the size of the image and making it thicker and thicker. But the size of the image is reducing. You can see from height is 572 to 570, and then 284, half, then again half, then again half. So these are called the layers of UNIT. And then as he becomes the teacher, he transfers the knowledge to the student. And this is called bridge network. So he again convolves and he uppools, just reverse of the brown arrow, he uppools them. And he borrows the process of getting the features which he has gotten during learning process. And now he wants to donate that knowledge to the students. So the idea is how much knowledge he can learn and become a teacher. At some point, he must donate to the world so he can become generalized. So he becomes, so he uppools, he wants to get to the original size of the image right here. But he wants to categorize into two objects, which he's targeting, the foreground object and the background object. So this process of UNIT allows him to become a teacher and train it and then generate students to become smarter. So this process of convolution is the trick. And by convolution, you can get mathematically the numbers you want. And then keep doing the process so it becomes single vector instead of image. So here's the whole image and it becomes a single vector, and then start getting back to the image process again. So he starts donating the knowledge. But while donating the knowledge, he must maintain what we call the original features. So he transfers the original people. He transfers the knowledge to the students by giving them in the process while regaining the shape, by regaining the reconstruction. So Olof saw the vision of doing this, and he's a professor in Germany. So this is a simple convolution where a deck of filters, this is a small filter which is convolved to the image, and he gets down through using the mathematical formulation to the value. And then he converts them into positive value using ReLU function. And then from that ReLU function, he again uses max pooling to get the best features out, positive features out. And then once he reaches to the end on the right side, he starts back again. So that is called back propagation. So the back propagation looks something like this, where he's transferring forward, then going back, forward, back, forward. One time he goes forward and backward is called one epoch. And he keeps doing that till it stabilizes. So what is going on is increasing the features, decreasing the image size. On the right, decreasing the features, increasing the image size. So the loss function, when it reaches on the other end, decreases and stabilizes, and accuracy starts increasing. It's a reverse, and the UNet takes care. All the networks like UNet are sisters and brothers of UNet, and we will see that. This is Segnet UNet, sister of UNet. It uses the same U concept, but triggers out another segmentation process in parallel and uses the same convolution. The only difference is instead of skipping from green to tortoise color, it skips from yellow to purple color. So it's unmaxed pooling operation. Here's a simple example of the lesion detection in carotid artery using the UNet. And you can see the UNet is compared against the gold standard, almost touching bumper to bumper. And it is done in a real time. It takes less than 1 second to do real time, but training may take certain time. So you can see almost all performance parameters touch 90 to 100. Jacquard index, dice, precision, specificity, sensitivity, and accuracy. We compared this UNet against the other standardized algorithms like EthroEdge2. You can see they're much better than the standard conventional methods, which are statistical-based methods, but the AI-based method is still touching 90. Even the ROCs of UNet is 93 and AUC is 95. So if we take the data, we found out using deep learning, we can identify those patients which are higher hypertensions and having high plaque lesions out of the cohorts. So you can do the same deep learning concept for tissue characterization, because we need to do an early symptomatic plaques identification who have low calcium, largely hyperechoic, which are darker in lesions and vulnerable to rupture. So we use the same concept of training using AI. Once the training is done, you can do the performance of prediction. And then you can do the heat maps where you can actually tell where the symptoms are present or where the darker hyperechoic lesions, which are hard to see, are present, which are low in calcium, darker. So here is an example with the lesions which are darker but vulnerable to rupture, and the heat map identifies them. The heat map itself is artificial intelligence based. So instead of using segmentation, it becomes like a classification domain where the same segmentation happens, followed by a small layer of dense layer which helps to characterize the lesion in the classification framework. Now, how do we use this under COVID framework? We already know that Omicron and Delta and all that has been active for a long time. And these top 5 countries has led us to the US. We have already crossed 800,000 deaths. That's unbearable. And now Biden is throwing another layer of boosters and et cetera, et cetera. So we already know the receptors are there and we get it grabbed. We also know there are 4 pathways leading to the lesion, and ultimately all these pathways lead to the brain injury or heart injury, whether it is acute respiratory distress syndrome, or it could be a RAS pathway or immune pathway. In the end is in the brain and heart. So we have to correlate these patients to do CVD risk assessment using AI. So now, if there is diabetes, we have a cyclic group of ketoacidosis. If there are no diabetes, it invites and it damages the A1C. And if you have A1C, it accepts the viral entry, leading to more aggressive A1C. So this is how we can include the CVD and lung imaging into the pipeline for the COVID patients. So even initially the robot analyzes and the COVID test is done, and if he's quarantined and lung images is continued, maybe CT or arterial imaging, and the GGO report or consolidation report or crazy paving report comes out, and along with the CVD. And at that point, you do the CVD risk assessment. There are 3 options. Either COVID is very bad, he has to go through ICU. But if the COVID is not at all there, only atherosclerotic disease is there, then he goes for the treatment based on the other comorbidities. And if there is no lung, no arterial disease, it's uninfected, and he waits for the second screening, and the process repeats again. So he can include the atherosclerotic lesion monitoring along with the lung monitoring in a setup like this. Now, how do we do the lung? Using AI, again, we will use the same concept of training using AI, and then quantification of the lung, and then being able to predict the lung. So here is a simple example of AI VVG segment or residual network segment compared to NIH segmentation tool. You can see the segmented mask comes out, overlay of the segmented mask, and the boundaries of the segmented mask. Here are the correlation coefficients and Jacquard index and dyes. You can see ground truth against the AI models almost in 95 range. And the Jacquard index, 80% of the patients have 0.94. So it's a really powerful scheme for detection of lung segmentation of COVID patients. You can do variability study using Coblias where more observers are trained. Because what do you need in AI? The ground truth is very, very crucial. So you can have many observers do the ground truth and then compare those ground truths and develop the AI using each ground truth and then do the variability analysis. So here are some results of the variability analysis for observer 1, observer 2, using different AI models here, all in the range of 0.98 to 0.6 ROC curves, whether you do left lung or right lung or combined lung. Then we have the same observer difference. It qualifies the FDA clearance rule that the difference between the observers should be less than 5%, which is what we have obtained throughout in the analysis, and our hypothesis is true. We also compared against the most standard protocol by NVIDIA, a company called MedSick, where they actually segment the lungs using AI, but they don't tell what the AI model is. And we can compare our model, hybrid model called VVG segment, against the MedSec. So one of them, red in the background, is MedSec, and the green is Coblias, our system of hybrid deep learning 1 and hybrid deep learning 2. You can see it's almost 1%. And this becomes, again, the regression correlation coefficients and the ROC curves against the 2 observers. So let us look, one more is important in these COVID patients is the lesion. Not only the lung, but we have to be identifying lesion of the lungs using AI. So we use VVG UNet, again, sister of UNet, which is the mother of all AI algorithms. You can see that these are the raw images with the high crazy pavings and GGO, but the ResNet units, our sister, catches the lesion. MedSec, our competitor, catches the lesion. And the doctor traces his lesions, the 2 observers. They're almost all same. This is very important to observe. Now, the last question lies, AI is, of course, powerful. But what people are missing is the bias in the AI. So all these studies were done in CVD and lung imaging, and we graded these studies and marked them how well the attributes of the AI were taken. So we took 40 attributes of AI, compartmentalized into 5 clusters, and graded them, and generated the butterfly model having 4 fins. Those which are losing the fins are having bias in the AI. So you can see that the fin is big here, and as we go down the road, the fin decreases. So these studies are very highly biased. They'll show high accuracy, but no clinical inference. They're not FDA clear, or they're not clinically active. So this is a simple example of the GUI, which is a responsive network for AI-based cardiovascular system. And you can see that we can choose any of the AI models and in AI generation, and we can compare deep learning, machine learning versus deep learning. So there are bidirectional RNN, LSTM, GRU. These are deep learning algorithms. The support vector machine, logistic regression, random forest decision tree, they are machine learning. And we compare against the conventional algorithms called conventional cardiovascular risk calculator. We can enhance the data using SMART. We can do ground truth labeling for training. Then we can predict in the routine mode, where we take the data and we predict the risk and generate the report real time when the patient is sick. So 12 million patients have been done, for example, and so on. So once the system is executed, the risk prediction report comes out and transmitted an email to the patient right away. So this is the real world application of AI in CVD, using all the parameters, maybe 40 of them around this. So with that note, I'll finish the system. But the AI we have been devoting on many applications, and our end goal is to get the FDA clearance, which is what we are striving and generating from generation 2 to generation 3, and so on, for thyroid, for Euroscan, for urology, for neonatology, for infant death or neonatal deaths, and for cardiovascular. With that note, I will only say a conclusion. AI is really a powerful tool. The normalization is very important during pre-processing. Optimization is very important for generalization. An excellent tool for segmentation and classification. And high-powered computing is needed for training sometimes. Transfer learning surely saves time. The bias in AI must be checked and removed. And the ultimate goal is to get an FDA on clinically adapted systems. We have collaborators in all over the globe throughout that. And we want to acknowledge and thank all the people who have been working and doctors who have been giving data throughout the world, especially Dr. Khanna right here. And with that note, anybody coming to San Francisco would love to share a lot of interesting work going on for the last 15 years only in AI. Thank you once again for giving this opportunity to talk to you all. God bless you, and thank you.
Thank you very much, Dr. Suri, and this was a part of the oration. Can we have the oration plug here displayed, Ujjwal? So we are going to give it to you in person when you're here.
Thank you.
It says, Dr. Gargi Khanna oration for the year 2021 has been conferred to Dr. Jasjit Suri, who is a world leader in the field of biomedical engineering and management, for the topic AI in carotid imaging and predicting stroke and acute coronary syndrome at the 13th Asia Pacific Vascular Interventional Course held virtually at New Delhi, India from 19 to 21st December for his distinguished contribution to the field. Asia Pacific Vascular Society wishes him many more years of good health, academic excellence, dated this 19th day of December 2021.
Thank you.
So, congratulations,